So we're live?
We're live.
Great. Okay. Well, good afternoon, everybody. So my name is Barry Servat, and I'm the statewide medical director of McPap, and it's my pleasure to welcome all of you to our November clinical conversations session. And today we have a wonderful opportunity to have a discussion about racial justice and health equity, and we have a wonderful speaker. And the title of the talk is Moving the Arc Towards Racial Justice and Health Equity, Self-Work Required. So before we get in, I'm going to introduce Dr. Kasper a little bit more fully, but just some housekeeping things. The session is going to be recorded, and as always, it's going to be available on the McPap website, which is www.mcpap.com. And you should bookmark that just because there's lots of really good resources on that site. It's kind of brings together lots of tools and guidelines and all kinds of resources. So the slides will be available on the site under the tools and resources, or toolkits and resources page. The presenter, as always, in this case, Dr. Kasper, is going to stop for questions periodically during the presentation, and you can also save your questions for the end if you prefer. If you have a question or comment, you can type it in to the question box, and we'll read out your question, or if you prefer to just ask it yourself, you can let us know that you'd like to do that, and we can unmute your line when the time comes to let you ask it yourself. And at the end, there's going to be a survey, and we really would appreciate just taking a moment to fill it out, just so we can have feedback for future presentations. So, Dr. Kasper, Dr. Jennifer Kasper is, she's a pediatrician and a global health practitioner and social medicine educator. And she's been committed throughout her career to clinical medicine, human rights training, and mentoring people. She's an associate pediatrician at Brigham and Women's Hospital and assistant professor of pediatrics and global health and social medicine at Harvard. She's the chair of the Harvard Medical School Scholars in Medicine Faculty Advisory Committee on Global Health. She also is a primary care pediatrician, and she directs the Pediatric Racial Justice and Health Equity program at Southern Jamaica Plain Health Center. She did her BA and MD in the honors program, actually with honors at the Boston University School of Medicine. And she also has an MPH from the Boston University School of Public Health. She is a past president and member of the President's Council of Doctors for Global Health. The Doctors for Global Health practices the so-called liberation medicine, the conscious and conscientious use of health to promote human dignity and social justice. And I'm sure she'll tell us more about that. They partner with rural communities in El Salvador, Mexico, and Uganda. Her domestic and global health expertise and publications include health service delivery, rural community development, complex humanitarian emergencies, strengthening of health systems, capacity building, and community health worker training. And they also do a lot of work in global health ethics. She's the co-editor of the Handbook of Pediatric Global Health, and she directs and teaches courses on social medicine, community engagement, and global health professionalism at Harvard Medical School. So with that, and without any further ado, I'll hand it over to Dr. Kasper for her presentation.
Thank you so much. And probably my most critical title is on this first slide. I am trying my best to be a lifelong learner in many, many realms. So I deeply appreciate this opportunity to both talk and share with all of you. And as I mentioned to folks before we got started, I am very much welcome being interrupted and if someone's having a feeling or wants to give some pushback. That's the nature of this work. And so I would love to hear from all of you. As was mentioned, I have been a member of the Southern JP Adaptive Leaders Racial Justice Lab since its inception in 2016. And so again, I'm really grateful for this opportunity to take you on a part of my journey. And really like, again, how this work and this training is landing within me, like kind of physically and emotionally, and how that's, informing how I care for patients. So this is certainly not a one and done academic exercise. And I hope you'll recognize that. And so what I'd like to do with this time with you is, we'll take a moment, we'll kind of settle into this moment, we'll settle into our bodies. We'll do an activity around identities and intersectionality. We'll review assumptions, which is sort of the bedrock of the racial justice work that I do with the lab folks. And then I'll go into, well, what do I mean when I'm describing self-work? And then I'll end with some liberation in the exam work that we're currently doing. So let's take a moment and borrow these very appropriate words from Arundhati Roy. And I quote, "Whatever it is, coronavirus has made the mighty kneel and brought the world to a halt like nothing else could. Our minds are still racing back and forth, longing for a return to normality, trying to stitch our future to our past and refusing to acknowledge the rupture. But the rupture exists. And in the midst of this terrible despair, it offers us a chance to rethink the doomsday machine we have built for ourselves. Nothing could be worse than a return to normality. Historically, pandemics have forced humans to break with the past and imagine the world anew. And this one is no different. It is a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcass of our prejudice and hatred, our avarice, our data banks and dead ideas, our dead rivers and smoky skies behind us. Or we can walk through lightly with little luggage, ready to imagine another world and ready to fight for it. So again, when I make this point of mentioning let's be present in our bodies, again, I'd like to quote from another very, very just brilliant racial justice speaker and writer, Resmaa Menakem. And so what he says is the following: so many of our efforts to address inequities and violence and hatred and dead and broken bodies in our streets have been conceptual, and they have failed. If we're going to make any progress, we need to start with the body. So one way that we do that in our racial justice kind of lab work is through this tool, the window of tolerance. And so you can see, there's this vacillating red line and kind of a hyperarousal, hypoarousal, and then kind of an optimal arousal state. So certainly the psychologist, the psychiatrist among us right now will be like, oh yes, this is our bread and butter right here. But why do we use this tool? Well, clearly, like if I am hyper aroused, I might tend to be kind of hyper vigilant, a bit in a panicky or anxious state, right? And maybe more prone to anger or agitation. Now, if something kind of the opposite, right? If I had a really bad morning or a fight with somebody, I might sort of come to a racial justice meeting or training in a very hypo-arousal state, right? I'm kind of numb, I'm shut down. And neither one of those extremes is where we want to be if we want to engage in the tough, brave work of racial justice. And so this optimal arousal really allows me, again, to be appropriately regulated, right? Because I may throw out ideas and feelings that might be hard for people to hear. My peers might have responses to my comments that are going to be hard for me to hear. So I want to be optimally ready for that. And again, this is just one tool that we can kind of put into practice to sort of tune into our bodies. And you know, and if we had the time, we would sort of go around the room, or you know, go into breakout rooms and have people do this. And I'll give you an example of it probably in the next slide. Uh, and so again, the activity that I'd love for us to engage in, and we're going to do the best we can, right, with our Zoom technology here. But again, if I were in, you know, kind of a racial justice circle or a training, we would all be absolutely starting our meeting by going through our identities. So I'll give you an example. So my name is Jennifer Kasper. My ancestry includes, I am Polish. On my father's side, I'm English, Irish, Scottish for my mother's side. I racialize as white. I use the she series, the she pronoun series. And I'm probably, you know, because I'm in front of all of you giving a presentation, I'm probably at about a 3, if I had to give it a number. And so let's just all, because I'd love to know in whatever sense we can share who is in the room here with me right now. I believe it's Sarah who's going to pull up 3 successive polls. So if you just take a moment and, you know, mark all of, I think you can mark all that apply. So how do you identify your race, ethnicity? So everyone go ahead and mark down what you have to say about it. And then I think, there we go. So we are 80%, 80% of us self-identify as white, 13% of us self-identify as Hispanic or Latino, and 7% identify as Asian. Let's close this poll, and then Sarah will now bring up the next one. And we'll see where we land there. So go ahead, what is your sexual orientation? If everyone would please take a moment and mark that as well. Okay, so 80% of us self-identify as straight or heterosexual, 7% of us identify as lesbian or gay, 13% of us identify as queer. And so now if we close this one, and then I think there's just one more, but let's see. Oh, our gender identity. So male, female, trans, queer, or another gender category. Sorry, we don't have the ability to do kind of a fill in the blank. There we go. Okay, so we are 28% of us identify as male, 67% identify as female, and 6% identify in another category. And then I think maybe the final one is the pronouns. Is that correct, Sarah? There we go. And what pronoun do you use? Let me see if I can get my arrow to work here. Okay. Okay, so 70% of us identify in the she, or you would presumably use the she series, and 30% identify or use the he series. So again, this is, and what I have up here on the screen is, you know, it felt, I'm sure it felt a little linear to, you know, kind of self-identify when, you know, we might also choose to describe our citizenship status. We might choose to describe, you know, being partnered or not partnered, with or without kids, and a whole myriad other, you know, series of choices. You know, I love the Audre Lorde quote, like, there is no such thing as a single issue struggle because we don't live single issue lives. And part of this exercise of identities and intersectionality, you know, comes from Kimberly Crenshaw's work, specifically looking at gender and violence against women. And if you're interested in that term, you can certainly look up her paper in the Stanford Law Review from 1991. But I'd love to just to take a break. Like, do people, you know, how does this land with people? Do people do this routinely? Any thoughts or feelings about it? Okay, well then I'll let Beth and the team interject if anything comes up as we kind of move along here. But let's move into this kind of next piece. It is really, really important for us as we do racial justice work to be clear on assumptions. And so when I engage in racial justice work, these are my assumptions, okay? My framework is going to be radical democracy. I want everyone in the room to be included. And my definition of racism is, as stated here, a system of advantage based on race. Okay, and so we also, like, as I understand it, for me, racism plus other systems of oppression over the years and decades and centuries have really created a power imbalance, right? So just as we can talk about a system of advantage based on race, we can also talk about a system of disadvantage based on race. And that those systems and that power imbalance leads to health inequities. The second assumption, culture eats strategy for lunch and breakfast and dinner, really refers to white supremacy culture. And again, this is, kind of the overarching um, operational theory in practice in our country, in the United States. And it has ramifications for the health and well-being of Black and Brown individuals, for immigrants, for anyone who identifies as non-white. Has issues for those folks, but also has issues for me as a white woman in this world. A third assumption is that in my racial justice work, I will lead with racism explicitly, but never exclusively. So again, what do I mean by that? Well, to the extent that racism is so deeply entrenched, specifically in the United States and in our society, as we work towards changing that and dismantling that and become equipped and advanced and adept at doing that, we are much better poised to then use that framework of dismantling to engage in and dismantle other systems of oppression. For example, existing patriarchies, ableism, classism, nativism, sexism. Um, so that's what we mean when I speak about, yes, I'm going to, for the purposes of this conversation, talk about racism explicitly, but never exclusively, right? It speaks, to that previous slide of intersectionality. Um, in racial justice work, we want to have both our heads and our hearts engaged. For those of you who are well-versed in trauma-informed practices, right? And the ways that all of us can create space and honor and acknowledge, create a space that feels safe and brave for the individuals we care for, that's equally important in this racial justice work. We can think back to that quote by Resmaa Menakem, right? We know that racism, not race, is a risk factor for poor health for the people who we may serve in clinical spaces. But what this head and heart piece also speaks to is us allowing ourselves to have feelings, okay? To permit ourselves to bring feelings into the space. And as my colleagues, Abigail Ortiz and Denny Butler McKay like to say, they say, we need to feel, to heal, and to deal. The fifth assumption here is please don't personalize the critique of systems. So it can be relatively easy for us to fall prey to kind of pigeonholing a discussion of racism to a focus solely on the interpersonal, right? Like, what implicit biases do I bring to the discussion? What snap judgments do I make? What prejudice do I have? What discrimination? But really what this racial justice work is requiring of us is, again, understand, getting structural, okay? Taking that 35,000-foot view, right? What are the programs, the practices, the policies that have been in place, that are currently in place, that reinforce the system of racism in which we all live? And we need to really examine how they're all interrelated and how they really do, like, hit people of color in the form of microaggressions daily or macroaggressions. But even though I've gone ahead and said, let's critique systems, not people, for this final assumption, now please make it personal. This is really about me bringing my whole self to this discussion, okay? And again, I would invite all of you to bring your whole selves to this kind of discussion. So I think that was a lot just to, share with you. I'm really interested in hearing, and again, I don't know if it's possible to have the proverbial show of hands or in the chat box, but who amongst us has been engaged or involved in racial justice work or a training, and is some of this resonate with you? Is this some of the things that you have discussed or learned, or maybe you have other things that you'd like to share? So just super curious, who
Hey,
amongst us
Jennifer,
had any training?
it's Barry. I just thought I would just jump in and let you know that we don't have a chat box,
Yeah,
but we have a question box, and so I think we could use the question box in the same way. Not everyone will see it, but if people type in comments and sort of contributions into the question box, Beth and I will be glad to read them out to people. So I just wanted to clarify that.
that's great. I mean, I guess then if there's a way in the Q&A box just to say for whom is this the first time you're kind of hearing this kind of conversation, I'd be interested, or kind of a corollary is, who has had some racial justice training, just to bring some other thoughts and ideas into the space if folks have them. So I'm not seeing the Q&A box light up, so I should assume that nothing is going on in there. Is that a fair assumption?
So far, we don't have anything in
Okay, no, that's fine. That's fine. I just want to be clear. Well, let me then go ahead and move on, because again, in my title, I put self-work required. So let me just.
Denny Butler McKay just said that she really is glad to hear this material in the forum, and Leah Diskin said it's not her first time, but she's always eager to learn more. And Denise Butler McKay also thanked you for this.
Okay, well, thank you both. They're very important to me over at Southern JP. So let me take some time to move into this piece around self-work. And maybe I will, I hadn't planned on bringing in any of my kind of global health work, but it's probably equally relevant in this space. So, when I think about self-work and, when a number of us came together to try and define, what do we mean when we say self-work? Because, the concern is that, we could all jump into this with, and I'll kind of pick on Barry. Barry may have his own ideas about racism, and I might have my own ideas, and Beth might have a different set of definitions, and we can jump in potentially with like all kinds of feelings like I'm not racist or get defensive or what have you. And so the self-work is really about, again, my kind of deep, both understanding, again, kind of from an intellectual perspective, but also like how this feels to me and what is happening inside my body, that either makes me, kind of lean in with relative comfort, or maybe like not want to lean in, but lean in with, you know, some relative discomfort, because part of the discomfort is also informative and a moment of teaching. And so, you know, self-work, again, this is just one way to sort of frame it, right? But, you know, first and foremost for me, I need to have and continue to grow in my understanding of structural racism and white supremacy in medicine and public health. And that can include things like, you know, race is a social construct. There is no genetic basis for the term race. Like, people are more different within so-called, you know, defined race categories than we are different white, Black, Asian, Latino, Hispanic. But we've created this social construct for race. And I think, you know, Dr. Kamara Jones says this so well. You know, she says, now, if I'm in the United States, I'm seen as a Black woman. I go to Brazil, I'm seen as maybe of European or Jamaican descent. I mean, so place matters and can inform how we are viewed by others. So just wanting to be very, very clear again about terms and you know, genomics as being at the present time very much a distractor, right? Like, to create an ACE inhibitor that's meant for Black patients is quite incorrect on many levels. You know, and racism in research, right? That includes everything from, you know, the Tuskegee experiment that affected sharecroppers in the South and went on for decades before somebody said, wait a minute, there is a treatment for syphilis. These people are being experimented on without their full consent. We could think about racism, you know, overseas with, you know, the AIDS, the ART trials in sub-Saharan Africa. So all of these concepts are really important to grasp and understand and get clarity around as part of the self-work. Another piece of the self-work for me is to, again, know and train myself, right? What are my identities? How might those change day to day, week to week? What is the shared vocabulary? You know, again, developing an understanding of how we racialize everyone and how that can have adverse health outcomes. Understanding implicit bias and how that is an aspect of perpetuating racism. Moving from this sense, you know, given all that I've said about, you know, understanding and, you know, intelligence and using my intelligence to learn and learn and learn, at the same time recognizing that this is not about, now I will become culturally competent in racism, but I will hopefully have a great deal more humility related to this topic. And also, again, understanding that all of this can't be explained by, well, it just has to do with socioeconomic status. Like, it's just poor people who have bad health outcomes. There's been some really, really careful, articulate research done around this, and socioeconomic status does not explain racial disparities. So that's just, again, another aspect of this work. Another piece is to know my community, right? So that also requires, what do I know of the history of Boston, the social determinants of health, the housing, the food insecurity, you know, primary language, immigration status, how all of those issues come to play in mitigating or exacerbating people's health. How might I be aware of the assets and the resources and the wealth of knowledge within particular communities? And how can I be an active participant? You know, it really reminds me of when I went to El Salvador, and you know, I thought I was going to be there for a couple of months to volunteer as a pediatrician, and I stayed for 2 years. And so during that time, I really got to know the community of rural campesinos in a mountainous group of villages in El Salvador, and hear their history and understand how the Civil War and decades of you know, racism against indigenous populations was writ large on their bodies. And then finally, another piece of the self-work is, bringing what I have learned and what I'm feeling into the exam room. And that might take the form of making the implicit explicit. That might be asking patients I'm caring for about their identities. That might be asking about experiences with racism in the healthcare system. That might involve shared power and decision making. And certainly it involves deeper listening. And let me just confirm here. So there's a question here. I'll stop there for a moment. So it does say here, does assumptions about racism include awareness and redressing power differences, personal and social, that exist given the history of social oppression, conferred privilege, unearned power, etc.? Trevelyan and Murray indicated this was essential two-step in cultural humility. I would definitely say yes, that it does, that not only is there the piece around becoming more aware, if I'm hearing your question correctly, but then it's the action step, right? So I've done a lot of no, and then kind of the fourth step of the self-work is now how might I then act on what I have learned and heard and experienced and so forth. But I really want to stress again the self-work is sort of the requirement. And again, it's not a one and done, right? Like we're all on this journey together and we're all at different moments in time. But the point being that it's important to get a deeper understanding and appreciation before we sort of launch into something. Because my intention may be great, but my impact may be quite hurtful. So maybe like with this as kind of, again, the framework, let me just give a couple of examples around some of this self-work. And so when we think about history, right, and the history of racism, I find this, this diagram quite informative. We've got a relatively brief history, right? If we start from around 1619 and chattel slavery, and then move through 100 years of Jim Crow segregation from 1865 through 1965, and then structural racism being kind of defined as 1965 to the present, like 87% of our history of the United States has been like deeply engaged or involved in and existed during the eras of chattel slavery and Jim Crow segregation. And what did our health system look like? Well, it was just getting underway. And I'll go into this a little more depth in the next slide, but right from the start, we have, disparate inequitable treatment. We have terms like a slave health deficit or the slave health subsystem in effect. What kind of research was going on at that time? Well, there was some research. This is just, again, one example. There was the first large-scale smallpox inoculation. Whoops, I didn't mean to go there. Let's see if we can go back. But that was inspired by an enslaved African man, Onesimus, pardon me. So again, and then if we think about Jim Crow segregation, and we had de jure segregation, we had de facto segregation, throughout most of the health system, things are still deeply segregated at every level, everything from the water fountains to who is cared for in which sections of a hospital. And there was research going on at this time, trying to make the case that, the actual brains and shapes of the brains of Negroes were different and smaller and therefore somehow inferior, or could explain, certain behaviors in Negroes and how that perpetuated mistreatment and ill treatment that resulted in poor health outcomes. And here we are today, right? Even if we just look at this piece around structural racism, in spite of the fact that we have had school desegregation and the Civil Rights Act and the Voting Rights Act, and we desegregated medical schools and we desegregated hospitals, there are still huge inequities in health outcomes. in treatment of individuals in healthcare spaces. And again, this is just one example, right? When we think about, racism and research, right? So this particular study that was published in PNAS in 2016 was a study of residents, okay? Residents in medicine. And they were asked if Black people perceive pain differently from white people. And the study found that greater than 50% of participants, so these are physicians in training in their residency programs, had inaccurate beliefs about biological differences between Black and white people as it pertained to pain. So again, when we think about this history, and then if I move to this next slide, again, here is where Harvard was established in the time of slavery. Mass General Hospital, established during the time of slavery. Children's Hospital Boston, established during the time of Reconstruction, post-Civil War. We've got the establishment of the Brigham and Women's Hospital during Jim Crow and segregation. So, it really begs the question, like, how could we not really be, at an institutional level, at an interpersonal level, racist? I mean, we were built during a period of time that continues to this day that is racist and has structural programs, policies, and practices that affect Black and brown people. Why don't I stop there for a minute and see if there are any, again, thoughts, feelings, pushback. How is this landing? Is this, the first time people are hearing this? Is this disturbing? I don't know. All right, well, let me let that historical, brief historical journey sit with everybody. And then let me move on to another piece, right? So I self-identified as, a woman who is racialized as white. And so I, like anybody else, needs to sit with and struggle with white supremacy cultural norms. And allow me just to read these out. And even if nobody responds, just see where these land in your bodies. Perfectionism, sense of urgency, defensiveness, quantity over quality, worship of the written word, one right way, one best way, paternalism, power hoarding, fear of conflict, individualism, scaling up or progress means bigger and more, objectivity, right to comfort, either or, sort of like a zero-sum game. So these are cultural norms that were created or kind of, enumerated by Teemu Kuhn and Kenneth Jones at Health Impact Partners. And again, I'm just sort of curious if anyone wants to kind of anonymously share in the Q&A, like, how does this land? Like, we are 80% self-identify as white. A smaller percentage of us self-identified as Hispanic and Latino, a smaller percentage self-identified as Asian. Maybe there's also some of us who want to, self-identify across a few different ancestries. But how does this land? How do these words on the page here? I mean, I think for me as a participant in this ongoing work and learning and training, the ones I struggle the most with are certainly perfectionism, certainly a fear of conflict, and defensiveness. And so I think some of my biggest challenges are, when I'm in a space, either with white allies or with, mixed races and ancestries and identities, there's a part of me that's afraid to speak because I'm afraid of what's going to come back my way. Um, and so that's, again, just something that I am going to continue to work on, so that I can be my best self, and be my best self to the patients who I care for. Let me move from that to yet another kind of
Jennifer,
moment that I had. And again,
Jennifer, if I could just ask a question.
please.
When you said, I thought it was really interesting and intriguing when you said that you're a person who was racialized as white. And I think that, you know, that sort of implies that that you don't, you know, have a sort of a agency in that sort of identification in a way. And, you know, contrary to kind of the question in the survey in the beginning, as far as like, how do we self-identify? You know, so when we self-identify, we're sort of personally, you know, having agency over saying that we're one race or another. And so I think, I wonder if you could expand on that point, because I think it's very interesting, you know, to sort of think of ourselves as, you know, not sort of being white, you know, those 80% of us who are, you know, self-identified as white, think of ourselves not necessarily being white, but sort of being assigned, you know, to whiteness. And I wonder if you can speak to that a little bit more.
Yeah, it's interesting, and I'd love to also hear your thoughts, Barry, and others. I do find myself, you know, like I'm, you know, how many times do I check off the box, like, you know, color in all that apply, or, you know, hit the button for all that apply. I'm like, white, I'm white, I'm white, I'm white. But I feel like as I have, again, engaged in this work, and, you know, and growing in this understanding of, you know, race being a social construct, that means, you know, the whiteness has been placed on me. Now, you know, I can accept and recognize and still, you know, in a sense, I don't mean to denigrate whiteness at all. But at the same time, there is a piece of me, whether I self-identify as white or I say like that whiteness has been put on me because of our white supremacy culture and our desire to kind of categorize people and, you know, otherize others, that, you know, I may, like, as I grow in this, prefer to be recognized as, no, I'm much more complex than that. I guess I think about a couple of things. I think about both, yeah, when do I feel comfortable self-identifying and sort of accepting my whiteness? And then also recognize, just as we racialize Black as Black or Asian as Asian or Latino as Latino, even though, you know, Cubans are distinct from Salvadorans, are distinct from Guatemalans, are distinct from, you know, mixes of those individuals. That there's definitely this kind of categorization also, I think, reduces our humanity, and reduces kind of the rich tapestry that we all are. You know, like for me to spend more time reflecting on being Polish and Irish and English and Scottish as my ancestry. So there's that kind of thought I have around it. But then I think the other piece to me is, you know, as I think about being racialized white, it's like I fall into the category of individuals who are advantaged. And so what does, you know, does that advantage and that privilege gives me, you know, lots of free passes into lots of spaces that people of color cannot easily pass through, if they can pass through at all. So yeah, so there's this piece of agency of, you know, I will identify as white and accept that, you know, I am white, at the same time recognizing that I am, that's also an external categorization that's been placed upon me just as we place these categories on other individuals. And, and if so I want to say that I'm white because of the ramifications, the implications in society for my Black and brown brothers and sisters, and also recognize that each one of us is so much more than these kind of discrete categories. But Barry, I'm super interested in whatever else you might have to say, and
Yeah.
and then there's a question that relates to this other piece.
Yeah, I think that it'd be interesting to hear more about the person who kind of contributed to the chat on this. But I think you really kind of articulated the complexity in a lovely way, and it strikes me that some of the ways in which those of us who are white, many people sort of are defensive about some of these cultural characteristics, of perfectionism and some of those other, sort of bullets, that we don't like that, but we also, happily accept, the benefits, that are conferred upon us. And so it is very complex, that we kind of push against, this assignment, of whiteness. But we also, have to acknowledge that we have received and accepted and utilized, the benefits of that as well. And so it is so complicated.
Mm-hmm. Yeah, and I think I deeply appreciate this question about white supremacy culture and these lists of norms. I wouldn't say that they are, unique to only, white supremacy culture. I do agree with you, for example, that, perfectionism exists in all cultures. Like I think all of us would, I think I would say that all people strive to be the best that they can be. And so I don't put up this list as if to imply that somebody who might self-identify as Black or Latino or Asian or Native American wouldn't also have some of these norms to deal with. So I don't know if that's a sufficient answer there. The specificity around the data that exists. Again, these words resonate with me as a white woman, but I don't think they are only part of people who identify as white. I think because white culture has been the predominant culture for so long, that maybe it would appear that these are more relevant, but I don't want to say that, because it's not as if they're more relevant or they're only relevant for white people. And I appreciate if somebody identifies as a different race and says, that's why I said, like, let these words kind of wash over you. And even if you don't, or maybe even better if you don't identify as white, and yet these words hold some resonance for you, then like, I think we all, I would argue, have work to do in recognizing, identifying, naming, and then trying to address these. But the person who asked the question, I don't know if that feels like enough of a response. Data from the scientific perspective, I personally don't know of like data that's been collected or a scientific study of this nature around cultural norms. If you know of one, please, by all means, share it. Okay, and I'll accept if the silence is that was a sufficient response for now. But I think another piece for me that's really, really been important, and again, given who I am and my multiple identities, is I think as I've, you know, sat in circles with people of various identities, with my Black and brown brothers and sisters, is I know I very much, and this somewhat ties into some of my global health work, I think, is, when I lived in El Salvador for 2 years, I was very intent on, you know, the injustices and the wrongdoing against the rural campesinos I was working with and serving and learning with and providing healthcare to. In like fashion, I think in my earlier days, and probably even still kind of continuing to this day, viewing racism as something that happens to those people out there, to people of color, also has a bit of a safety, because it's kind of, I'm kind of distancing myself in my use of those words. But my aha moment has to do with this word liberation. And again, it is slowly, kind of both resonating within my consciousness as well as kind of sitting within my heart. And what I mean by that is, my liberation is tied up in your liberation. Is it tied up in the liberation of people of color? And rather than seeing it as an issue facing those other people out there, um, when I recognize that we're all living in the same society that is racist to varying degrees, um, that when we liberate sectors of our society, then we can all get free. Um, and so that has been a tremendously potent kind of experience that I've had, and that I'm continuing to work on, is this notion of collective liberation. Um, and so maybe now, that final step in the self-work was all about, well, now how am I bringing this to the exam room? So, for right now, what does that look like? I am definitely trying to interrupt less and listen more, with the intention to understand and not with an intention to have my response ready. Um, I definitely explicitly name racism and structures and policies and programs that work against um, a number of the children and adolescents and families that I care for in the clinic. Um, and I talk about how these structures can impact the health and well-being of the kids. So I'm explicit about that. And then finally, from a more collective perspective, another way that, this is kind of brand new, hot off the press, way that my colleagues and I are bringing liberation into the exam room is through this pediatric racial justice study. And this is just a direct quote of what we're sharing, of what we're going to share with the patients we see, which is, just a little bit of a reflection on, there's a lot of attention right now about race and racism. In our clinic, we're strongly committed to social and racial justice. The American Academy of Pediatrics is recommending that we start having very early discussions, because there is scientific evidence to demonstrate that, infants as young as 6 months can recognize race in faces. And so we want to engage and begin a discussion about race in our well child visits. And so we're going to be asking the parents and caregivers these 3 questions. Are you having conversations about race and racism or anti-racism in your home? And if so, how are those going? We've got a handout with resources to help start and support these conversations. Would you like a copy? We have it in English and Spanish right now. And then lastly, is there anything that you feel we can do to further support you during these times? So again, haven't even gotten the study started. If and when we start to, collect stories and some data from this, would love to share this with you. But I think I'll just close there. Again, my intention was to, take you on a journey of, both being in our moment in history, being in our bodies, thinking about how we regulate or dysregulate, how do we identify, how do all those identities intersect? How do longstanding issues of policies, procedures, practices, programs, at the government and legal level have impacted the health and well-being of people that we care for and serve in clinic? And that, racism isn't like that thing that happened hundreds of years ago and like, that's done. Like we're still on that road, as Ta-Nehisi Coates would say. And so again, thank you for just this opportunity to share some of my experiences with you, and would love to hear final thoughts or feelings, please.
So it looks like we have a question in the Q&A box. This is all interesting. I have some background with these issues. However, the time the most of us have had patients is really limited. Can you please address how this could be beneficial in that setting? Is there more community work rather than individual patients that's more effective and realistic?
It's a great question. And, so totally hear you on the, our time with patients is so limited, and kind of sporadic, right? I mean, for some, if we're lucky, we get someone who has maybe some chronic illnesses, we might see them every 3 months, but otherwise, healthy kids don't come to the clinic. At the same time, I think there are some of the things that we've talked about in our groups are things like, it's my job to get you. So it might be something like, I'm curious, like, how do you identify, or how would you like me to identify you? Or how would you like me to refer to you? Kind of that question about, am I putting a name on you, or am I allowing you to answer for yourself? It might just be a curious question, right? It might be kind of an opening statement that normalizes the experience, which is to say, I think a lot of people in Boston or wherever you might be have had, challenging experiences with the healthcare system, or maybe have had, experiences that they would term racist. I'm just curious in my efforts to provide you the best care I can, has that ever happened to you? And would you want to share that? And I just feel like, something like that, as you're kind of running through your list around developmental milestones and what they eat, and, are they using the bathroom okay? And how's their sleep? And, things around screen time. Like, I feel like, posing that question is pretty deeply personal, right? And intimate. And, if nobody's got anything to say about it, like, they'll just tell you, like, I've never had that happen to me. Or like, why ask me that? Like, can we get on with the physical? And, so maybe you'll have your moment of discomfort, right? But other people are living, with, days upon days of multiple moments that are uncomfortable. And so I would just encourage, even if it's just one question, it feels like a way to connect and have some shared humanity about, our healthcare system. Or like, I had to take my mom, who's cognitively limited, to the healthcare, to her doctor, and he kind of brushed her off on a bunch of stuff. Like, was that necessarily racist? No, but like, does that speak to ageism and people's ability to communicate clearly and effectively with the elderly who may be cognitively challenged? So,
Jennifer, we have one more question. I think that could be our last one, sadly.
okay.
So Leah Diskin was asking, what would you say are differences between culture that supports liberation as opposed to white supremacy culture? And it reminds me of the point that you made earlier on about how culture eats strategy for breakfast and lunch and dinner. And so how, are there any practical ideas that you have about how we can do our part, as doctors and clinicians, to change the culture around racism?
Right. So, I would say, I would say that there's these opportunities at an individual level, right? Like with every single patient you see, if you wanted to take a moment either to reflect on identities or to reflect on, racism in the healthcare system. Like many people are like, they're living that experience. So I would hope that the majority of patients would be like, wow, I'm so glad you brought that up because this is what's going on. I think other ways to also kind of develop this culture of liberation would be also like, how do we treat the staff with whom we work, right? Like what kind of culture do we have, within our PEDS practice at Southern Jamaica Plain Health Center? What is our culture of practice within the entire Southern Jamaica Plain Health Center? How am I treating my colleagues who are of different races, ethnicities, identities, ancestries? I mean, that's something that, is, I would argue, life promoting and, using some terms that I use with my kids all the time, warm fuzzies as opposed to cold pricklies, right? So, and those happen, on a daily basis if we're in clinic on a daily basis or interacting with our colleagues. I think if people feel drawn to community work, I'm absolutely, and and you have the bandwidth for that, and whether you do that as an individual or a family, again, that's there, we could have talked just about all the different, community-based organizations that deal with housing and food and domestic violence and immigration issues just right here in the greater like JP area. So I think that's another strategy. And then continuing conversations with allies, right? Again, whether you self-identify as gay or straight or Asian or Latino or white or non-white, like having conversations with your colleagues about this. And wow, I just heard what that person said. That felt racist. What did you think? Or, or I've been thinking about this, or I've been reading about this, or I'm having a difficult time with this. I think the more opportunities we just share in conversation, the proverbial water cooler, even though we can't really stand next to water coolers anymore, will go a long way. Like it's all these small threads that are going to make the tapestry. And I think that is, if I had one point to make is, in a way, like white supremacy culture would be like, oh no, it's got to be huge, it's got to involve millions of people, or it's not worth anything. I think all of these, if the microaggressions and macroaggressions are happening on a daily basis, then why not let's be countercultural and create micro moments of connection and shared humanity, and acknowledging where we are, but where we would like to be, and how we're working towards a more equitable healthcare system and world.
Well, with that, I think we unfortunately do have to close, and I just want to extend my deepest thanks to Dr. Kasper and everyone for joining us in this discussion and thinking about this together with us. And so thanks so much for joining us, and we're going to have to end, but we'll see people next month. And please encourage you to fill out the questionnaire at the end that you'll get as a pop-up when you sign out of the meeting. But thanks again, and thanks everybody for attending.
Barry, actually, we won't have a meeting, no December. Next Wednesday.
Oh. Gosh, thank you, John, for clarifying that. Of course, that's going to get in the way. I think it's too close to the holidays. So we will see people in January.
Okay, and be well, everybody, and be safe.
You too.